Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 464 of our pharmacotherapy series, which majors in adult hematologic malignancies. This video discusses the case of patient JVC from part 463. 24 hours after JVC's induction chemotherapy was initiated, the following laboratory values were obtained: a WBC count of 78,000 cells per microliter, potassium levels of 5.3 milliequivalents per liter, phosphorus levels of 6.0 milligrams per deciliter, uric acid levels of 9.8 milligrams per deciliter, calcium levels of 6 mg per deciliter, creatinine levels of 1.6 mg per deciliter. So my questions to you read: why have these laboratory values changed so suddenly? Could this have been minimized or prevented? How should these metabolic disturbances be managed? JVC presented with a very high number of peripheral blood blasts. On administration of chemotherapy, patients with a hypercellular bone marrow and high number of blast cells can have a rapid lysis of the blast cells and the release of cellular contents. This can result in tumor lysis syndrome, abbreviated as TLS, which is associated with metabolic abnormalities such as hyperuricemia, hyperphosphatemia, hypercalcemia, and uremia. These disturbances may lead to arrhythmias and acute renal failure. In most cases, tumor lysis syndrome occurs 12 to 24 hours after chemotherapy is initiated. Tumor lysis syndrome may occur after therapy for other malignancies, particularly in those with a high tumor burden, such as high-grade lymphomas and acute lymphocytic leukemia. It rarely occurs after therapy for solid tumors. Patients should receive IV hydration, that is 3 to 4 liters per day, beginning 24 to 48 hours before chemotherapy to maintain renal perfusion, optimize the solubility of tumor lysis products, and compensate for fluid losses caused by fever or vomiting. Alkalinization of the urine with the addition of sodium bicarbonate to the IV fluids may also reduce or prevent uric acid from precipitating in the renal tubules and collection ducts by maintaining the urate in its ionized state, but is not currently recommended for all patients. This is because the increased pH may increase the risk of precipitating calcium phosphate in both soft tissue and kidney tubules, and it may aggravate hypercalcemia. Allopurinol, a xanthine oxidase inhibitor that blocks the production of uric acid, should be started before chemotherapy to prevent or minimize the complications of tumor lysis syndrome, abbreviated as TLS. The recommended adult dosage is 300 to 600 mg per day. JVC's serum uric acid and electrolytes should be monitored at least 2 to 3 times a day for 24 to 48 hours after initiating chemotherapy. If severe abnormalities occur, more aggressive measures should be initiated. Allopurinol may be discontinued if the serum uric acid is within normal limits, the lactate dehydrogenase has normalized, and the WBC count is low. Rasburicase, a recombinant urate oxidase product, can also be used as prophylaxis in patients who are at high risk of developing tumor lysis syndrome or for the treatment of patients who present with or develop tumor lysis syndrome. Rasburicase acts as a catalyst in the enzymatic oxidation of uric acid to allantoin, which is 5 to 10 times more soluble than uric acid and undergoes rapid renal excretion. The recommended dose of rasburicase for both prevention and treatment of tumor lysis syndrome is 0.2 mg per kilogram per dose IV. Rasburicase results in a rapid reduction in serum uric acid within 4 hours of administration, and is generally well tolerated. In many adult centers, doses of 3 or 6 mg are commonly used. Although rasburicase has demonstrated excellent efficacy and tolerability, its optimal role in the prevention and management of hyperuricemia in adults remains to be defined because of its high cost and lack of a randomized trial comparing its effect with other interventions. Although JVC's serum potassium was low on admission, it has increased significantly as a result of tumor lysis syndrome. For this reason, replacement potassium therapy by any method is not recommended before chemotherapy in patients in whom tumor lysis syndrome is highly likely. In extreme circumstances, dialysis may be required to correct severe metabolic and electrolyte disturbances associated with tumor lysis syndrome. JVC's kidneys continued to function throughout. Even though JVC's creatinine was above the normal range, his urine output did not decline substantially and he was able to proceed without further intervention. JVC received allopurinol therapy and aggressive hydration throughout his induction chemotherapy. The metabolic abnormalities gradually resolved as his WBC count declined and tumor lysis diminished. So my question to you is, what other complications may occur during induction therapy and can they be treated? Patients receiving cytarabine and idarubicin induction therapy develop profound anemia, granulocytopenia, e.g., WBC count less than 100 cells per microliter, and thrombocytopenia, that is less than 20,000 platelets per microliter shortly after therapy is initiated, which usually persist for approximately 21 to 28 days. Additionally, all infectious complications must be considered life-threatening in severely immunocompromised patients such as JVC fulgrastim, granulocyte colony stimulating factor, abbreviated as GCSF, and sargramostim, a granulocyte macrophage colony stimulating factor, abbreviated as GMCSF, stimulate leukemic cells as well as normal granulocyte precursors in vitro. However, several studies have demonstrated that these agents, when used as an adjunct to acute myeloid leukemia chemotherapy, are safe and do not adversely affect disease outcome. Most studies have demonstrated that colony-stimulating factors, abbreviated as CSFs, can modestly decrease the length of profound neutropenia and sometimes reduce the incidence of infection-related morbidity, the duration of systemic antibiotic and antifungal therapy, and the number of hospitalization days. Despite the reduction in short-term neutropenia-related complications, Administration of colony-stimulating factors after induction chemotherapy does not appear to have an impact on the rate of CR or the long-term outcomes of the disease. Severe thrombocytopenia may result in bleeding episodes that range in severity from oozing gums to massive hemorrhage. Serious bleeding complications can usually be avoided if patients receive platelet transfusions when their platelet counts decrease to less than 10,000 cells per microliter or when patients experience bleeding. Other common drug-induced complications that may occur during induction therapy include nausea and vomiting, mucositis, fever, and skin rash. After completion of his induction chemotherapy, JVC's WBC count fell to less than 100 cells per microliter and his platelet count fell to 5,000 cells per microliter. He received platelet transfusions approximately every 2 to 3 days to prevent bleeding complications. On day 9, he developed a fever of 38.8 degrees Celsius. He was started immediately on empiric, broad-spectrum antibiotic therapy for fever and neutropenia, and it subsequently resolved. On day 29, his WBC count was 5,600 cells per microliter with a normal differential, and his platelet count was 168,000 cells per microliter. He received packed red blood cell transfusions on 2 separate occasions when his hemoglobin fell to less than 7 mg per deciliter. A repeat bone marrow aspirate showed no evidence of persistent leukemia, and JVC was told that his leukemia was in remission. Nevertheless, his hematologist recommended additional chemotherapy, and JVC questions why this is necessary. So my question to you reads: is post-remission therapy necessary? And if so, what therapeutic options are available to JVC? We will briefly consider the rationale. Although greater than 60% of patients treated for acute myeloid leukemia achieve CR after induction therapy, the median duration of the remission is only about 12 to 18 months, and only 20% to 40% of patients have a disease-free survival exceeding 5 years. Short remissions have been attributed to proliferation of clinically undetectable leukemic cells. Thus, the rationale for administering chemotherapy after remission is to eradicate these residual cells. In adult acute myeloid leukemia, post-remission therapy, also referred to as consolidation therapy, includes 3 to 4 cycles of chemotherapy. Clinical trials have shown that high-dose post-remission therapy results in a higher percentage, that is 30% to 40%, of long-term, that is more than 2 to 5 years, disease-free survivors than either no or low-dose post-remission chemotherapy in patients generally younger than 60 years of age. Post-remission therapy regimens usually include high-dose cytarabine alone or in combination with one or more agents such as an anthracycline or etoposide. Patients 60 years of age and older or those with comorbid disease may not be able to tolerate this intensive post-remission therapy. In these circumstances, the risk of life-threatening toxicity may outweigh the potential benefits of post-remission chemotherapy. Allogeneic hematopoietic cell transplantation has also been studied in the post-remission treatment of acute myeloid leukemia. In conclusion, JVC should receive consolidation therapy after high-dose cytarabine induction, because this has been shown to give him the best chance of long-term survival. Additionally, because JVC was fortunate enough to be diagnosed with good-risk disease, he will not require an allogeneic hematopoietic cell transplantation. He will be followed closely with at least bi-monthly CBCs and a bone marrow biopsy at least every year for 5 years after consolidation. This close follow-up is vital for catching relapse as early as possible with the intent of going immediately to an allogeneic hematopoietic cell transplantation and minimizing additional reinduction therapy if relapse occurs. Because JVC does not require an allogeneic hematopoietic cell transplantation at this time, his hematologist recommends 3 courses of high-dose cytarabine as post-remission therapy. 1 week after he was declared to be in remission, JVC is readmitted to the hospital to receive high-dose cytarabine 3 grams per meter squared every 12 hours, over 3 hours, on days 1, 3, and 5. So my question to you reads: what are the potential acute and delayed toxicities associated with high-dose cytarabine, and how can these effects be prevented? At conventional dosages of 100 to 200 mg per meter squared per day, adverse effects associated with cytarabine include myelosuppression, fever, and skin rashes. Occasionally, liver enzymes rise transiently. The side effect profile for high-dose cytarabine, that is greater than 1 gram per meter squared per day, by contrast, is very different and can produce major cerebellar, ocular, and skin toxicities that present as rash or palmar-plantar erythrodysesthesia, abbreviated as PPE. We will now briefly look at cerebellar and ocular toxicity. Cerebellar toxicity is a significant problem in patients receiving high-dose cytarabine therapy. Ocular toxicity results from damage to the corneal epithelium, occurring when cytarabine penetrates the epithelium through the anterior chamber of the eye or tears. Symptoms include conjunctivitis, excessive lacrimation, burning, ocular pain, photophobia, and blurred vision. Artificial tears, that is 2 drops every 4 to 6 hours, administered concurrently with high-dose cytarabine, generally prevent these symptoms. Corticosteroid eye drops can be used as an alternative to artificial tears or if symptoms of conjunctivitis occur. The next question reads: would recommendations for induction and post-remission therapy differ if JVC were elderly, that is 60 years of age or older? As mentioned earlier, the incidence of acute myeloid leukemia increases with advancing age. At age 40 years, there is only 1 case of AML per 100,000, but the annual incidence increases to 15% at ages older than 75 years. The prognosis of patients with acute myeloid leukemia is also directly related to age. Older patients are generally less able to tolerate intensive induction and post-remission chemotherapy. Older patients often have comorbid medical conditions and a poor performance status, which are directly associated with worse outcomes with conventional acute myeloid leukemia therapy. Many single-institution and cooperative group studies exclude elderly patients with acute myeloid leukemia or treat them on a separate, less intensive protocol. Elderly patients are often judged to be poor risk candidates for intensive chemotherapy without objective review of available criteria. Because the median age of patients with acute myeloid leukemia and myelodysplastic syndrome is 67 years, the results of regimens studied in younger patients may not be applicable to the elderly. Some hematologists believe that it is most appropriate to offer older patients supportive care only, low-intensity therapy, or investigational treatment. Others believe that moderately intensive chemotherapy is beneficial in some candidates. However, most physicians feel uncomfortable offering intensive chemotherapy to elderly patients because of the high risk of induction mortality. Several studies have addressed the outcome of elderly patients. The selection of post-remission therapy is difficult in elderly patients because they have a higher risk of morbidity and mortality, and more important, no clinical trials have demonstrated the benefit of post-remission therapy specifically in the elderly. The intensity of the regimens must often be attenuated because there is risk of serious toxicities. This is particularly true with high-dose cytarabine therapy because of the increased risk of cerebellar toxicity in the elderly. Studies have shown that post-remission therapy with low-dose cytarabine, 100 mg per meter squared by continuous infusion for 5 days, is as effective as high-dose cytarabine and better tolerated in elderly patients. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 465.